Hello?
Hello, sir.
Present can.
Hello.
Hello. Call present can.
Hello, sir.
Hello. Hello there.
අදංග හෙනවා සර්. පොඩ්ඩක් ඒත් සර් වොලියුම් අඩුයි වගේ.
Hello there.
ඇහෙනවා සර් ඇහෙනවා.
Okay. Call present can.
Sir, hello, sir.
කාර්තික.
Hari Karta. Okay.
Okay, sir.
Yeah, you can start.
Okay. Yes. So, since the patient was drowsy, I have taken the history from his wife, sir.
Okay, that's fine. No problem.
He is Mr. Kamal Sri, 66-year-old, father of 3, from Peliagoda. He is a known patient with chronic liver cell disease with recurrent episode of hepatic encephalopathy and the diabetes mellitus for 1 year duration, currently on oral hypoglycemic drug.
Okay.
This time presented on 29th of August with reduced level of consciousness since morning of 29
Okay.
until 27th of August, which is 2 days back from the admission. He was apparently well, and where he developed reduced oral intake because of the reduced appetite, and the same day he has been vomited once, which contained food particles. Then the next day also his oral intake was markedly reduced, and also family members has noticed there was altered behavior. However, they did not get any medical advice. Then the next day morning, which is 29th, they have found the patient's conscious level was reduced, where patient did not respond to the family members.
Okay.
The same time, family members did not notice any abnormal movement of it, no mouth deviation. There was no fever, headache, or any difficulty in exposure to light or sounds during the course of the illness.
Okay.
And also, they denies any substance abuse. There was no history of drug overdose, especially the hypoglycemic drug or any sedative drug.
Okay.
And this patient did not known with any chronic renal disease, so there was no uremic symptoms to suggest to uremic encephalopathy also.
Okay, sure.
And also there was no recent history of head trauma. And apart from the reduced oral intake and one episode of vomiting, there was no precipitating factors for hepatic encephalopathy. And there was no blood stain vomiting or dark stool, and there was no history of infection. There was no fever or no cough, and there was no abdominal pain or swelling to suggest spontaneous bacterial peritonitis. And patient bowel opening was normal, which is 2 times per day. That is normal to that patient as usual.
Okay.
And after the family members found the patient conscious level is reduced, they have brought the patient to the NHSL.
Sure. Okay.
Then about his past medical history, he was diagnosed with decompensated liver disease in 2019 April, when patient was presented with bilateral lower limb edema.
Okay.
He's a non-patient with alcoholic, where he has taken 1 bottle per day for more than 40 years. However, after the diagnosis, after the medical advice, he has abstained for 1 year durations. Following the diagnosis, about 5 months later, that is 2019 September, patient was presented with reduced level of consciousness and the dark color stool. That time, upper GI endoscopy was done and informed that his vein has been enlarged in the lower esophageal areas.
Okay.
And also banding was done. Also plan given to repeat the upper GI endoscopy in 6 weeks of time.
Sure.
In the
Okay.
same admission, sir, the ultrasound also has been done,
Mm-hmm.
which reveals some abnormal growth, but the wife did not know about the fine details, sir. And also, but they have told there has to be done CT on 21st of September, sir.
Sure.
Um, Following that admission, there was subsequent admission with a reduced level of consciousness, which is one is 2019 October with the
Mm.
constipation and the reduced level of consciousness. They have managed as hepatic encephalopathy.
Okay.
Similar to that, there was also two admission in the two admission where one is with the cellulitis and the reduced level of consciousness, and other one also constipation and the reduced level of consciousness. So there was altogether there was 4 episode of hepatic encephalopathy in the past.
Okay.
For the recurrent constipation, they have been given some rectal suppositories. If there was no bowel opening, they advised to use the suppository. And my
Sure.
wife is did not aware about any prophylaxis for the upper GI bleedings.
Okay. Sure.
And about his diabetes mellitus,
Mm-hmm.
he was diagnosed 1 year back
Mm-hmm.
uh, when he presented for his liver problem
Mm-hmm.
and started on oral hypoglycemic medication.
Mm-hmm.
According to the wife, his complaint was good. However, his glycemic control was poor.
Okay.
There was no side effect to the medication, such as any gastric irritation,
Mm-hmm.
and there was no hyperglycemic emergency also in the past.
Mm.
Um, uh, so there was no tightening type chest pain to suggest an ischemic disease, heart disease, or there was no limb weakness, or there was no claudications.
Okay.
Um, So according to the wife, patient did not have any numbness in the leg and there was no visual problem. However, wife is did not aware about the frothy urine and the amount of urine.
Okay.
And also, according to the wife, after the diagnosis of the diabetes mellitus, they have been done the endocrine screening. However,
Mm-hmm.
they did not aware about the results.
Okay. Okay, Karthika. Yeah.
Okay. And they have the glucometer at home, sir, to measure the glucose level in an emergency. And they
Mm-hmm.
have the understanding about the diabetes mellitus. Also, they have
Right.
refrigerator at home. Also,
Mm-hmm.
willing to use insulin if it's necessary. And
Mm-hmm.
his younger daughter is willing to inject the insulin if necessary.
Okay.
His surgical history is unremarkable, sir. He is did not allergic to any food, drug, or plaster. There was no family history of diabetes mellitus or liver disease. Also, there was no family history of malignancy.
Okay.
He's previously employed as a three-wheel driver, an artist, and a journalist. Currently, also he's a father of three daughters. Currently living with wife and youngest daughter. Youngest daughter is a 21-year-old who is studying in a university.
Mm-hmm.
His wife is unemployed. They are earned by renting a room. They are earning around 5 to 7,000 per month. However, due
Okay.
to this admission, their financial status was affected. And as I mentioned earlier, he is a chronic alcohol abuser and
Mm-hmm.
abstinent after the diagnosis. And he's a non-smoker. Their nearest hospital is
Okay.
NHSL, which take about 30 to 45 minutes to reach.
Sure.
And his
Okay.
wife is aware about the condition and the possible possible cause. But however, they did not aware about the future prognosis.
Okay.
Shall I proceed with my examination, sir?
Yes, just give us the important sort of positive findings on examination.
Um, on examination, sir, patient was drowsy,
Okay.
and however, he was lying comfortably on the bed, not dyspneic. There was NU tube inserted, and also
Okay.
cannula was inserted in the left forearm with the IV infusion going on. There was
Okay.
documented fever on the fever chart. He was
Right. Sure.
averagely built man, afebrile, not pallor or not icteric. However, there was a features of dehydration where his skin turgor was reduced.
Okay.
And there was a bilateral parotid enlargement, but there was no Dupuytren contraction.
Okay.
Except the sparse body hair, there was no peripheral stigmata of liver disease such as Peyronie's, gynecomastia, or palmar erythema.
Okay.
There was no angioedema also.
Sure.
On abdominal examination, abdomen is not distended. There was no dilated vein, also
Mm-hmm.
no scar suggestive of past
Okay.
peritoneal tap. And on palpation, there was a tip of the spleen was
Mm-hmm.
palpable. However, there was no
Okay.
hepatomegaly or
Sure.
free fluids. And I also wanted to do the rectal examination to see any
Mm-hmm.
loaded rectum or to exclude
That's
any
fine. Very good.
bleedings.
Okay.
On the
Okay.
CNS exam,
Yes, Karthika, what do you find on
CNS
CNS exam?
GCS was 11 out of 15, sir. And the reflexes was present. However, I couldn't carry out the to assess his power of the limbs because patient was drowsy at that time.
Okay.
And the respiratory cardiovascular examination was unremarkable.
Okay. Did you find any flapping tremors on examination? Asterixis.
So I tried, sir, because patient was drowsy. I couldn't carry out elicit the flapping drums.
Okay. Right. That's not absolutely correct, Karthika. You can do it. Obviously, you can't ask the patient to stretch the hands out, but you can on your own. You can stretch the hands out and just press back on the wrist. Okay, and then you will get it if it's present. So the patient doesn't necessarily need to cooperate with your examination to do that. So that's minor point that you need to remember. Okay, can you summarize your history and examination for us now? And I hope that the rest of the people, I told you on the first day that you have to sort of write down a summary as the person presents. So and compare a summary with Kartika's summary now. Would you just like to present as a summary?
Yes, sir.
Yeah.
This is a 66-year-old non-patient with decompensated cirrhosis with recurrent hepatic encephalopathy and
Okay.
diabetes mellitus for 1 year.
Sure.
This time presented with reduced conscious level for 1 day
Mm-hmm.
duration
Mm-hmm.
associated with reduced oral intake for 2 days duration and 1 episode of vomiting. There
Okay.
was no history of hematemesis or melena, no
Mm-hmm.
constipation, no evidence of infection.
Okay.
On
Fine.
examination, GCS was 11 out of 15
Mm-hmm.
and there was a features of dehydration.
Okay.
Rest of the examination was unremarkable.
Okay. Right. Okay. So yeah, so that's a very good history and examination again. I'll come to some details there as we go on. So right, so this is again a very common long case. You can hear me neither.
Yes, sir.
Right. So this is again one of the commonest long cases that you will get in your exam. Okay. Obviously, there are plenty of patients with liver cell disease admitted to wards every single day, and you need to be very, very clear about the management and other aspects of this condition, right? Of course, we won't give you an unconscious patient for the exam. Don't worry. The patient will be able to give you a history. Okay, so don't worry about that. This patient might be challenging, obviously, because he's drowsy to take a history from. But remember, we will generally give you a very cooperative patient for your exam, and you don't need to worry about that too much. Okay, so that's just a thing that you can just don't worry about it. Okay, so I will take this discussion like we did on the last long case that we did, and I will sort of simulate, as it were, the sort of questions that would be asked from this patient. Now, before this session, you have had lectures on liver cell disease. I myself have taught you about liver cell disease. And obviously, you know a little bit of the background of the theory because you've done this in your modules before. So what I'm going to do now is I am going to use that and give you the possible questions that they would ask from this case. And remember, these are generic questions. May patient වගේම any patient with liver disease, these are the sorts of questions the examiners will ask you. And remember, I told you that these classes are mainly for exam preparation. Okay, fine. Now, the first thing that the examiner will ask in this case is, obviously, we'll start from the presenting problem. Okay, and the first question is obviously, now this patient is drowsy and the presentation is with drowsiness, okay, an altered level of consciousness. The first question the examiner will ask you is, what do you think the cause is for this patient's altered level of consciousness? So that is the first question that we should try to answer. Now, again, when you're answering this question, it's nice if in your head you have a sort of classification that you can work with. So unconsciousness in this patient could be related to his liver disease, or could be an alternate cause which is not related to his liver disease. So that's how you start your differential diagnosis. Okay, so say, I think that this patient has altered level of consciousness. This might be related to his liver disease, or it might be a cause which is not related to his liver disease. Obviously, given the circumstances, a cause related to his liver disease would be most likely. එහෙමත් කියන්න. Okay, given the circumstances, a cause related to his liver disease would be most likely. So what are the causes related to his liver disease? Okay, what are the causes related to his liver disease? Obviously, first thing would be hepatic encephalopathy. So you would say the first thing you would think of is hepatic encephalopathy. Okay, hepatic encephalopathy. Now, what features would make you think of hepatic encephalopathy? Right. And let's apply that to this patient. So say, I think this patient might have hepatic encephalopathy. And the reasons for me thinking so are 1, 2, 3, 4, 5. And you need to list the justification for your answer. And this is how you get the maximum marks. Okay. So why do you think this is hepatic encephalopathy? Number one, the patient has recurrent episodes and admissions with hepatic encephalopathy. Okay. And that is one of the things that make us think, right, that this episode could be due to hepatic encephalopathy. So past history of recurrent admissions due to hepatic encephalopathy. Number two, okay, if the patient had asterexis or flapping tremors, that would be one of the key features of hepatic encephalopathy on examination. And you can look for that even if the patient is drowsy. Okay, you just hold the hand up and press the wrist back. Okay, and you will see the flaps coming. Right, so that is the two key things that you look for. Recurrent episodes of hepatic encephalopathy, obviously the patient would be at a higher risk for developing hepatic encephalopathy. Number two would be flaps. Also, going back into the history, remember that one of the first symptoms of hepatic encephalopathy is personality change. And you might be able to elicit that from the family members. Okay, so that is another evidence. Personality change would be one of the earliest symptoms of hepatic encephalopathy. Other symptoms of hepatic encephalopathy that you need to ask for, and if they are present, they are strongly suggestive of the diagnosis, are altered sleep-wake pattern, okay, or day-night reversal. That's another way we describe that. Okay, so the fact that this patient had recurrent encephalopathy strongly favoring the diagnosis now. You can also look for flaps and also ask for early personality change and also this day-night reversal, okay, in the history. Okay, day-night reversal in the history. Okay. So this is very good evidence to suggest that the patient has hepatic encephalopathy. Fine. The next thing is, remember, hepatic encephalopathy is part of the spectrum of decompensated cirrhosis. Okay, it is a manifestation or part of a spectrum of decompensated cirrhosis. So if the patient has encephalopathy, the patient will have other features of decompensated cirrhosis. So that is the next point you bring up. Other features of decompensated cirrhosis, which are jaundice, okay, jaundice, upper GI bleeding, so that is hematemesis melina due to variceal bleeding, okay, ascites, okay. So these are the three other clinically diagnosable associations that you see in decompensated cirrhosis. So encephalopathy is one, but you might have other evidence of decompensated cirrhosis such as upper GI bleeding, ascites, and deep jaundice. And remember, in all patients with decompensated cirrhosis, you will find, if you can elicit a splenomegaly, that is what is evidence of portal hypertension. So splenomegaly might be a feature as well. Okay, if you can elicit it. Sometimes it's difficult to elicit because of ascites. So the එහෙම ලස්සනට කියන්න ඕනේ. Okay, so what could be causing the drowsiness or altered level of consciousness in this patient could be liver related or might not be liver related. If it's liver related, very likely that this patient has hepatic encephalopathy and is evidenced by the fact he has recurrent hepatic encephalopathy. Look for flaps, look for the history of altered sleep-wake patterns, okay, personality change, okay, and then look for other symptoms and signs of decompensated cirrhosis. And you can justify your answer. You can justify your answer. Okay. And also remember that hepatic encephalopathy may be triggered by commonly by constipation and dehydration. So this patient has constipation and that's been causing hepatic encephalopathy in the past, and that is again a good evidence that it is that. Right. So that is the first thing that you think of. Okay. Now, what other causes can present with this altered behavior, altered level of consciousness, which are related to liver disease? Okay. I would say that the next thing that we would think of are electrolyte imbalances. Electrolyte imbalances. Especially hyponatremia is very common in patients with liver disease. Hyponatremia. Okay. And that is often due to diuretics. So that's another possibility. Okay. The second thing that can occur is hypoglycemia. Hypoglycemia. And remember, liver patients have very low glucagon resources. So they get hypoglycemic very, very quickly. And the fact is, diabetes and oral hypoglycemics, that increases the risk of hypoglycemia. So possibilities are hyponatremia, hypoglycemia. Right. The third thing that could be related, sort of electrolyte imbalance, could be due to uremia. And remember that in cirrhotic patients, they could have hepatorenal syndrome. Hepatorenal syndrome. That could be causing uremia and altered level of consciousness because of that. So see the way I'm answering, examine එක කතා කරන්න chance එකක් දෙන්නේ නැහැ. You just keep on talking, right? Until they stop you, you just keep on talking. Okay, right. So could be hepatic encephalopathy, could be an electrolyte or metabolic imbalance such as hypoglycemia, hyponatremia, or uremia. The third thing is, we mentioned that this patient is has alcohol dependence. Now, even though he has stopped, we still don't know whether he's been taking alcohol. So it could be alcohol related as well, right? So these are all in relation to his liver disease and alcohol use. Remember that alcohol use patients, thiamine deficiency and Wernicke's encephalopathy. Okay, Wernicke's encephalopathy, thiamine deficiency, very common in patients who are alcohol dependent and have liver disease. So Wernicke's encephalopathy could be another possibility to explain this altered behavior. Okay, Wernicke's encephalopathy. Right, and that might be an explanation. People who are taking alcohol and stop taking alcohol, they might have the altered behavior might be part of alcohol withdrawal. Like a may patient adala naha because he's not using alcohol. He says he's not using alcohol at the moment, and that's for more than a year. Okay, that's what Karthika told us. But if you have a patient coming in who is taking alcohol a lot and stops taking alcohol, they might get altered level of consciousness, seizures, and cause tremors due to alcohol withdrawal. So these are some of the causes that you would expect in relation to alcohol use, in relation to liver disease. Okay. Now, what are the other causes that could be causing his altered behavior which are not related to liver disease? He has diabetes. So either hyperglycemia or hypoglycemia could be possible. And we've already discussed that hypoglycemia is they're at a higher risk in liver disease patients. So it could be that. Okay. Right. It also might be due to central nervous system causes like intracranial bleeds or infection. Okay, so these are all things that you'd consider in your differential diagnosis. Okay, could this be a primary central nervous system problem like a bleed or an infection? Right. Okay, fine. Okay, fine. So these are the things that so the first question is how would you what is causing the altered level of consciousness in this patient? And then you say it could be liver alcohol related or it could be alternate causes. Liver related, obviously, this patient probably has hepatic encephalopathy, and you justify your answer by giving these points. And then give the other possibilities as well, this which I have listed. I hope that is clear. Okay, so that is the way you answer. Then the next thing they will ask you is, right, fine, most likely diagnosis is hepatic encephalopathy. How would you manage this patient as a house officer? Okay, so let's discuss that. So hepatic encephalopathy, how you manage this patient? It's an emergency, obviously. Hepatic encephalopathy is an emergency. And then you obviously start off with the airway breathing circulation. Now remember, because the patient is drowsy or unconscious, you have to be very careful. They might have a compromised airway. So in your management, the first thing they will that you need to come up with is to tell the examiner, fine, I will look for a compromised airway and manage the airway first, right? You might need to get the intensive care doctors to come and see the patient, right? Because to consider whether they need any advanced form of airway management. Okay, so that is the first priority, right? That's the first priority. Then if you talk about hepatic encephalopathy management itself, then of course you need to talk about lactulose, okay, or getting the bowel opened with enema, for example. Okay, so bowel opening is a very important aspect of the management. And then we use lactulose. Okay, of course the patient has to be conscious enough to take the lactulose, or you might use an NG or something if that is not possible. Then exam එක හරිම frequently අහනවා, why lactulose? How does it work? And I have taught you this before. Okay, how does it work? There are three main actions. One, it sort of washes off, because of its laxative effect, it washes off gut bacteria. Okay, it washes off the gut bacteria, which are the producers of ammonia. මේක අනිවාර්යෙන් අහනවා. හරි, මේ ජාතික ප්‍රශ්න. What I am telling you is the other questions that we ask everybody who has a liver disease patient. So lactulose washes off the gut bacteria due to its laxative effect. Second thing, remember that lactulose in itself is an acidic substance. It's an acidic substance. So therefore, it kills the gut bacteria. Okay? Because of the acidity, it actually kills the gut bacteria or destroys the gut bacteria. Okay. Number 3, because of the acidity of lactulose, it converts ammonia into ammonium, and that is not well absorbed across the gut. Okay, so it converts ammonia into ammonium, and that is not absorbed across the gut wall. And these are the 3 reasons why lactulose is useful. So airway protection, getting the bubbles opened, edema, and then lactulose. Okay, but remember, patients should be able to swallow safely to take lactulose unless there is an NG tube. Then you need to know the actions of lactulose and why it is useful in hepatic encephalopathy. Washes off the gut bacteria, kills the gut bacteria because of acidity, and also converts ammonia into ammonium, which is poorly absorbed across the gut wall. And that's how it promotes in that sense. Okay, so that is important. Then you need to use antibiotics as well, and metronidazole or rifaximin are the 2 antibiotics that we use. And remember, these have to go directly into the gut. Okay, so via the enteral route. And also now we believe that metronidazole rifaximin is mostly useful in preventing recurrences of encephalopathy as well. So they're actually more useful in people who had a past history of encephalopathy. Okay, past history, they are more useful in a people who have, especially this sort of patient who has recurrent encephalopathy in the past. Right, so these are the 3 things that we use there: bubble opening, lactulose, enema, airway protection, and then antibiotics. You also need to address the underlying cause, which is often infection, like SBP, for example, spontaneous bacterial peritonitis. And if you suspect that, covering with antibiotics is very reasonable, and the antibiotic is ceftriaxone that we usually use. Okay, so underlying cause, infection, SBP. And upper GI bleeding is the other common precipitant of encephalopathy. So make sure that you say you will do a rectal exam, look out for hematemesis melina, to consider that as a possibility. Because remember, I myself have taught you that when you have upper GI bleeding, in essence, you swallow a high protein load, and that sort of knocks you off. Okay, that knocks you off. Okay. Right. So that is the answer to how you would manage encephalopathy. Now remember, ඔය ටික හොඳට කියාගෙන ගියොත් එහෙම, then they will ask you a slightly more difficult follow-up question. Now encephalopathy is essentially a clinical diagnosis නේද? දැන් අපි කියවනේ කොහොමද ඒක clinically diagnose කරන්න කියලා. Recurrent encephalopathy තියෙනවා නම් more likely. They get personality change, they get sleep-wake reversal, and they get flaps. And also they will have other features of decompensated liver disease like upper GI bleeding, deep jaundice, and ascites. How you know, that is essentially clinical diagnosis. How you would confirm the diagnosis, there are a few things you can do. At the bedside, there is a very nice thing that you can check for, and that is called constructional apraxia, where you get the person to draw a 5-pointed star. And සමහර වෙලාවට විභාගෙදී ඕක අහනවා. And you can show it, because you can ask the patient to draw it on your piece of paper that you take for the exam, and then you can show the examiners that you check for it. That is a very good thing to look for, and that adds to the clinical diagnosis. Laboratory looking for ammonia is a non-specific investigation. It is very expensive as well. It is not routinely done. Okay, not routinely done, but it is elevated in patients with encephalopathy. Right? But it's not routinely done because it's extremely expensive, and it's not done in our lab. Okay, so that is one thing. The other thing is, if you do an EEG on a patient with hepatic encephalopathy, you get this classical triphasic slow waves on the EEG. Okay, triphasic slow waves on the EEG. And that is something you see, and this is a question that some people love to ask, especially Professor Senaka Rajapaksa loves to ask this question: what do you get in the EEG in a patient with hepatic encephalopathy. Okay, and that is triphasic slow waves. Hari. Keparako kahala mandanno හැම කෙනාගේම අහනෝක සාමාන්‍ය. He loves to ask this question. Okay, so this is how you manage and තව අමාරුවේ දාන්න ප්‍රශ්න ටිකක් තියෙනවා අහන්න පුළුවන්. Always remember that you have to be very careful if the patient has ascites and encephalopathy. සමහරට එහෙම ලෙඩ වෙනවා. ඒතර ඒක අහන්නේ be careful that ඔය tap කරන්න අනම්මන යන්නේ නැහැ. එතකොට ඒ වගේ ලෙඩ. So that is a trick question. Okay, so somebody I think this patient encephalitis and ascites, why wouldn't you do a tap for the ascites? ඒ වගේ ප්‍රශ්න වුත් generally you don't do taps and things when they are encephalopathic. Okay, because that can actually precipitate it further. හරි. ඒතර ඔය ප්‍රශ්න ටික තමයි ඔය වටින් අහන්න පුළුවන්. Okay, ඔය වටින් අහන්න පුළුවන් ඔය ප්‍රශ්න ටික තමයි. Okay, so starting off with the differential diagnosis, then focusing a little bit on the management of encephalopathy, and remember, protect the airway, make sure that the airway is safe. Okay, then start the patient on bowel opening, lactulose and antibiotics. Look for the cause, and obviously you might sometimes when the diagnosis is unclear, use ammonia and EEGs to make the diagnosis. Okay, sometimes. Okay, don't do unnecessary like tapping ascites in patients with encephalopathy. That's basically that. Hari, so ඒක ගැන අපි කතා කරා දැන්. Okay, then moving on. Then what they will ask you is, they might ask you about this patient's long-term management. Okay, so say this patient recovers from encephalopathy. How would you optimize the long-term management? Okay, and how you would answer that question, Balamu. Now I'm going to give a generic answer for that question that would fit any case. Okay, how would you optimize this patient's long-term management? Now, if the patient, now, the first thing that we do in these sort of situations is look for the cause and make sure that we are absolutely certain that we are sure of the etiology. Because there are some things that we can treat. Even if the patient has liver disease, chronic liver disease, there are some things you can still treat. So make sure that you are absolutely clear about the etiology. So in your long-term management, the first part of the management is make sure that you are dealing with the etiology properly. Now in this patient, it is obvious that the patient is having alcoholic liver cell disease. Homework වලට හොයාගන්න how much alcohol you need to drink to cause cirrhosis. I think I might have taught you in your modules. හරි ආයෙත් මතක් කරගන්න. So here it's very, very clear that this is alcohol related. Okay, very clear. The next commonest cause of cirrhosis is metabolic liver disease and NASH. So make sure that you consider that as well. මෙයාට diabetes තියෙනවා. And that is probably contributing as well to his cirrhosis. Okay, but in some people who don't take alcohol, NASH cirrhosis is a very common cause. The other rare combination of diabetes and cirrhosis is hemochromatosis. Okay, the other rare combination of diabetes and cirrhosis is hemochromatosis. Okay, hemochromatosis. So make sure that you grasp the etiology and make sure that, especially in all patients, ask about a history of drug use, especially Ayurvedic medication use. And we see quite a lot of cirrhosis due to long-term Ayurvedic medication. Occasionally, we find hepatitis B and C. And very, very rarely in females, sometimes you find things like autoimmune liver disease. Right? But those are very, very rare. Right? For your exams, obviously liver alcohol is the key thing. Then obviously you focus a little bit more on NASH cirrhosis and obviously exotic things like diabetes and liver together, like hemochromatosis. But make sure that you also look for hepatitis B, C, and rarely things like autoimmune liver disease as well. So make sure that you have a clear idea of the etiology. That's the first step in the long-term management. Second step is try to reverse that etiology. Alcohol, now obviously you can't reverse it, but you can limit the progression by stopping alcohol use. Okay, so And in psychiatry, you had a very good, obviously, lectures and long cases on alcohol. So please apply some of that even in the medicine long case. Okay. So alcohol use, stopping alcohol. What are the strategies which you can use? ඒවා හිම්මම අහන්න පුළුවන්. So fine. So get a grasp on the etiology, reverse the etiology if possible, or try to limit the progression. Right. Then obviously you have to optimize the medical management. Okay. And how would you do that in the long term? Make sure the patient's bowel opens well, right? Ascites we usually manage with diuretics, spironolactone being the drug of choice, and you can add on furosemide if that doesn't work, right? Diuretics. Okay, that's the medical part of the management. Etiology first, reverse the etiology, then optimize the medical management. Bowel opening, lactulose is fine. Then you obviously put on the diuretics, spironolactone being the first line, then furosemide added on if that does not work. Okay. And also, if the patient has had an episode of spontaneous bacterial peritonitis in the past, remember that they need to be on cotrimoxazole lifelong, okay, on antibiotic prophylaxis, or a quinolone, one of the two, okay, cotrimoxazole or a quinolone antibiotic. The next thing is, if they have variceal bleeding, you need to treat that, and that might be done endoscopically with banding ligation, and then the patient would be given medication to reduce the portal pressure. And Karthika mentioned the patient was not sure whether they were on it. This patient should be on it. So make sure that the patient gets that. Okay. So varices, endoscopic banding ligation, and also you reduce the portal pressure, and the drug of choice is a beta blocker. Now people prefer carvedilol, but we used to use propranolol. Now people use carvedilol quite a lot, okay, for that purpose. Okay. Also, if they are alcoholics and things, you might also supplement them with thiamine. Okay, thiamine. Right. So in this patient, make sure the patient is not taking alcohol, stopped alcohol. Look at the patient's drug chart. If you're optimizing medication, make sure that you treat this patient's constipation well. Make sure that there are some diuretics if the patient has ascites, right? The patient should be on carvedilol for variceal bleeding prophylaxis, and then the patient should also might be on thiamine as well. Okay. Karthika, what are the drugs this patient is on? Did you manage to get the list of medication the patient is on?
Yes, sir. He initially started on IV hepatoxine, 1 gram Itaverli, IV omeprazole, and IV thiamine, oral carvedilol, oral metronidazole.
Okay, fine. So we have discussed why these drugs might be used then. Okay, so alcohol, optimizing the medical management of the patient, right? And then the last thing that you will do is obviously in the sort of optimization of the menu, the last thing, but the third thing you do is to make sure the patient, consider the patient for liver transplantation. Okay, you need at least 1 year of alcohol abstinence to be considered for that. And there are many scoring systems that we use to assess the suitability as well. Okay, use the MELD score very often and the Child Pew score, okay, to assess the suitability for transplantation. And obviously they need to be alcohol abstinent for at least 1 year. And then that's a different pathway. You don't need to know or worry about that. The fourth thing you do in the long-term management is surveillance. At least an annual endoscopy is indicated in these patients. And if there are varices, you band and ligate them. Okay, so varices, banding, ligation of varices need to be done. Then you need to surveillance them for liver cancer. Because remember, cirrhosis, patients are at a higher risk of developing liver cancer. So you surveil them for liver cancer. And that is usually with ultrasound scan and an alpha fetoprotein annually. Okay, annual ultrasound scan and an alpha fetoprotein. Because at a higher risk of developing liver cancer, especially if they have hepatitis C, the risk is actually much, much higher. Okay, so ultrasound scan and alpha fetoprotein would be also indicated. Right, fine. So these are the things that you would use in the management, sort of to in the long-term management of this patient. Right. Right. Now the next thing they will ask you in this particular patient. So you ask 2 or 3 questions. First thing I asked you was what is causing the drowsiness or altered consciousness in this patient, and we have discussed how you would discuss the differential diagnosis. Then I asked you, right, encephalopathy is the most likely thing. How would you manage that as a house officer? Okay, and we have gone through the steps of management. They give you some additional questions about EEGs and things in hepatic encephalopathy. Third question I asked you is fine. How would you manage or optimize the management of this patient in the long term? So what are the things? So looking at the etiology, looking at the drugs, medication, prevention of upper GI bleeding and so on, then going on to talking about liver transplantation suitability, and then surveillance with endoscopy and looking for liver cancer. So these are some important things that you discuss, right? The next question is, now this patient also has diabetes. What are the specific challenges that you would anticipate, right? Because they are diabetic as well as they have liver disease. What are the specific problems that you will anticipate? The first thing is the risk of hypoglycemia. I've already discuss that fact a little bit. So remember that these patients who have liver disease don't have much glucagon. Okay. And also, most of the time, their pancreas is damaged because of alcohol. And they have chronic pancreatitis on top of all of this. So they have a risk of getting hypoglycemic. So you have to be very careful in that. And you need to select your oral hypoglycemic drugs so that they minimize hypoglycemia. That is one challenge. The second challenge is metformin. So patients with end-stage liver disease and especially decompensated liver disease, metformin is not a good idea because it can cause lactic acidosis. What is this patient on, Karthika, for diabetes? Karthika? Hello, Karthika?
Yes, sir.
Yeah, what are the diabetes management? What is the diabetes management patient?
So initial 195. So they have withheld the metformin and started on subcutaneous soluble insulin, sir.
Okay.
So during the hospital stay, they have managed with the subcutaneous insulin.
Right,
You know,
which is
in
very
this step.
reasonable. Yeah.
Yeah, on
And
this
what
step.
was the creatinine? 195?
CBS was 195, sir.
Okay, right, fine. So yeah, so in the acute stage, most of the time we use insulin, but remember metformin is a bit of a problem in these patients who are decompensated. Okay, that's fine then. Okay, so those are some things that you might be asked, like this type as diabetes and liver disease. What are the special problems that might arise? So medication related problems are the ones that would arise in that situation. Okay, now, the last thing that we have time for in this sort of discussion would be they give you a scenario of a sort of another emergency. Say, patient comes with upper GI bleeding. What do you do? Okay, or patient while in the ward develops upper GI bleeding. What do you do? And I'm just going to brush on the basic principles. Then I'll obviously revise this when we talk about emergencies in more detail. But in a long case, what are the principles of management if this patient comes with upper GI bleeding? Obviously, fluid resuscitation, blood transfusion. And blood transfusion, remember, avoid over transfusion. That's very important. Generally, you transfuse to a target of around 9 grams per deciliter. Okay. Over transfusion can actually increase the risk of bleeding. Okay. Over transfusion can increase the risk of bleeding. Fine. So fluid resuscitation, blood transfusion, make sure that you don't over transfuse. Around 9 would be a good, reasonable, safe target. If you over transfuse them, people have found that they have higher risk of bleeding. Okay. Then moving on, for the upper GI bleeding per se, specific management is with terlipressin. That's very good for variceal bleeding, and it's the primary indication for terlipressin, variceal bleeding. If you don't have terlipressin, octreotide is the second line drug. Terlipressin or octreotide. That's very good for variceal bleeding. It basically constricts all the varices and stops them from bleeding. Right? Then moving on, okay, we also give them a PPI intravenously in most cases because these patients actually have a higher risk of gastric bleeding as well. And that is because of something called portal gastropathy. Okay, because of portal hypertension, the stomach wall erodes sort of. Okay, and they have a higher risk of bleeding through the stomach. Okay, so a fluid resuscitation, then terlipressin octreotide, IV PPI, and then additionally you also cover them with a broad spectrum antibiotic because they are at a very, very high risk of developing SBP. So people who have upper GI bleeding have a very high risk of developing SBP. So you generally cover them with a broad spectrum antibiotic for like ceftriaxone, for example. Okay, right. So that's fine. Okay, and that is absolutely fine. Okay, is that okay? Right. Then obviously you need to watch out for hepatic encephalopathy, treat it. And most of the time in our wards, we do give them metronidazole and lactulose as well, just as a precaution. Right. Okay. So all of this is we do, and then ultimately you need to get the patient into an endoscope, right? At least within 24 hours of admission. Okay. And remember, endoscopic treatment is very, very effective for variceal bleeding. Okay. More than medical management, endoscopic management is very, very effective. So you push the patient, try your best, and obviously endoscopy is available in all hospitals, most of the hospitals, at least district general level. So you need to get that in, and interventions are very effective for upper GI bleeding. Okay. So those are the principles of management of upper GI bleeding in a patient with cirrhosis and portal hypertension. Okay. So fluid resuscitation, blood transfusion, then focusing on terlipressin octreotide, prevention of SBP with ceftriaxone, manage encephalopathy if it occurs and also prevent it, and then finally endoscopy. Okay. And then when the patient recovers, as we discussed, the patient needs secondary prophylaxis, okay, so that it doesn't happen again. And for that, we use beta blockers. Carvedilol is the drug of choice. Somebody asked a question, why is carvedilol used? There is no very specific reason, Nadini, but people believe that it's slightly more effective than propranolol. The other question is, yeah, I think I've answered the other questions. Yeah, when you're using diuretics, be very careful because you can trigger encephalopathy in decompensated cirrhosis. And then IV dextrose, we don't routinely give normoglycemic patients with encephalopathy. Okay? Right. So those are the questions that can be asked from this particular case. Okay, so let's just summarize what we've discussed. So Karthik has described a very good, given a very good history and examination of a patient with liver disease and diabetes. Okay, and the patient has presented drowsy or in altered level of consciousness. And we asked about 6 questions from this long case, and these are general questions that can be asked from any patient with liver disease if you get it for a long case. First question is why the patient is drowsy and your differential diagnosis. So then you say could be liver related, could be alcohol related, or it might be other reason. Most likely liver related causes encephalopathy, and it is because of these reasons 1, 2, 3, 4, 5, 6 that I say this is encephalopathy. Also, it could be due to electrolyte imbalances like hyponatremia, hypoglycemia, and or uremia due to hepatorenal syndrome. If the patients continue to take alcohol, it might be alcohol withdrawal. Okay, it might be Wernicke's encephalopathy. Okay, so these are the things that could be related to alcohol. Other alternate causes might be diabetes-related hypoglycemia or hyperglycemia if the patient has, might be a primary central nervous system issue like a bleed or an infarct or an infection in the central nervous system. So these are the differential diagnoses that you'd consider. Okay. Then we went on to discuss, right, fine, encephalopathy. What are the treatment options that are available? We listed all of them, and we also diagnosis of encephalopathy is primarily clinical, but you can use elevated ammonia and triphasic slow waves on the EEG as in some patients if you're not sure of the diagnosis, right? Okay. Then we talked about how to optimize the long-term management of this patient. Etiology first, so there are several points. Etiology, see if you can address it, so you can prevent the progression. So in alcohol, you need to prevent the progression by stopping alcohol use. And remember, they might ask you a few psych-related questions. So how to stop and what are the strategies and cycle of change or something, right? Pre-contemplation, contemplation, whatever. So they might ask you that. Some physicians like to ask those sort of questions. So then moving on, what medication the patient should on, and the basis for these medications will be asked, why a beta blocker and all of these things. So you need to make sure that you need to make sure that you consider the patient for liver transplantation. And the fourth thing is you need to surveillance the patient for hepatic tumors and also for annual endoscopies for varices. Okay, that's done. Then upper GI bleeding, how would you manage as a thing? Principles, fluid resuscitation, blood transfusion, medical management, and then additional management or adjunctive management like giving ceftriaxone, for example. Right. Then this patient has diabetes and liver disease. What specific challenges will you encounter and how would you manage them? So the main problem in this is hypoglycemia, because liver disease, you are anyway prone to hypoglycemia. And some of the medications, metformin would be a problem in patients with sort of decompensated liver disease. Okay, and that would be a problem and would be a contraindication because it can cause lactic acidosis. Okay, fine. Any questions? Any questions? Hiru?
Yes, sir.
Did you have any teaching last few days? I'm sorry I couldn't do it because I was on call last week.
Today, Katulanda sir did a class on diabetes, sir.
Okay, good. And last week?
Last week, sir, Champika sir took some long cases on anemia and acute fever. Before that, no teaching, sir.
Okay. No, that's fine. So that's okay. So this week, no problem, we can do. So that's not an issue.
Okay.
Right. Okay. Any questions? Hiru, make Karnavidhi shape neither. Is there anything that we need to change, or would you like to do anything more? Kira mata kiyanna hala. There's any suggestions or anything? And make a cadden nani, the connection a cadden nani kata karnapura?
No, sir. No.
Right. Chamindi, so there are a few more questions I'll answer before we stop. Rifaximin or metronidazole. Rifaximin is a bit more effective. Yeah. Minon, yeah, can decompensate CLCD without jaundice. Very unusual. So if you have decompensated, you usually have deep jaundice. Minon. So, right. And rifaximin is now more favored than metronidazole. It's probably a bit more effective than that. Okay then. Right. That shortness of breath case, what is the diagnosis? That heart failure, that chronic heart failure.
Yes, a heart failure patient is there.
Yeah, shall we discuss that then tomorrow?
Okay, sir. Okay,
Right. So time I will message you.
okay, sir.
Okay. Hari. Okay. See you tomorrow then.
Okay. Thank you, sir.
Thank you, sir.
Yes, sir.
Thank
Thank
you.
you, sir.
Thank you,
Thank
sir.
you.
Thank you, sir.
Thank you very
Thank you,
much,
sir.
sir.
Thank you, sir.